Top, the right
Yes.
top there.
Now,
Okay,
¿nos
so
escuchan? Ah, ya, perfecto. Muchas gracias. Y ahora sí, Tiago, perdón. Sorry.
So sorry to those that are online that were not hearing us. So I will begin again. So thank you again for the invitation. I'm very happy to be here. Thank you so much for those who are here in the room. They already went all of the morning with me, so they are not tired yet. Expect. And thank you so much for those who are online and are here to hear me talking about perinatal mental health. So I just have to share with you one funny thing that was not what I planned, but you know that my shirt is really the same of the pattern of. And I was just looking now, so I think this could be a good sign of the presentation today. So according to the organization of the talk, I will do the talk first, and then in the end we will have the time for some questions. I expect to spend 1 hour and a half on the presentation, and I think we have time to discuss. And I really hope to have your inputs. I'm really able to explain better the studies that I'm presenting to you today, and I hope this could be a nice time for us to discuss the issues related with perinatal mental health. So just to begin the presentation, I bring you this question. When Flavia told me, okay, we need to define a title for the presentation, and I decided to propose why it is important to study perinatal mental health, because it's a question that in our team we are always discussing. Why is it important to study this? Why are we doing this kind of research? This is important for the practice. This is important for the families. So I think we will finish the presentation and we'll still have the same question, I guess. But we can reflect that this is a good way. So we know that perinatal mental health problems are a public health issue. Okay, there is a lot of evidence on this, because we know that when untreated, perinatal mental health problems can interfere on parental health, both at physical and psychological levels, can interfere with couple relationship during the transition to parenthood, can interfere also on parenting and co-parenting related processes, and of course, at the end, it can interfere on the child development and mental health. We have a lot of studies showing that perinatal mental health problems can interfere for several ways: biological, psychological, and psychosocial, can interfere on child development, on mental health. And of course, according to this evidence, we know that we need to provide timely and adequate mental health care in the perinatal period. So we need to address the needs of the parents, both in the mother, in the father, and trying to help them transition during this transition. However, we know that there are still huge gaps in perinatal mental health care. And to begin, I will present you a recent study that we published in Ata Psiquiátrica Scandinavica that was about unmet needs in mental health care for women with perinatal, clinically significant symptoms of perinatal depression or anxiety during the COVID pandemic. Okay, this is the first thing. This is a study that was conducted in the COVID pandemic. Now we are trying to replicate these results, and we are finding really the similar thing. So I think is not so different. So just to show you, of course, we don't have any study on men. Okay, this is the next step. But for the women, we use data from one Rise Up Cost PPD that we had, a project that we had during the COVID pandemic. And if you can see, if you look for Shield, for instance, okay, and you go for the women. So here we have the group that does not have clinical symptoms of depression or anxiety. So are the people that should not be receiving any treatment, any mental health care treatment. And then here we have the groups of women that have or depression or anxiety, okay? And then if you look to Shield, you know that only 13% of women receive treatment of those that have a problem, a mental health issue of depression, okay? And then if you look for anxiety, we go for the 12.4%. And then if we go for the group that has comorbid symptoms of depression or anxiety, that can be the higher risk group, for instance, we have like 20% almost of mental health care. And this, if you can go throughout the countries, this is not specific of South America. This happens also in Europe and in other parts of the world. So as you can see, in the highest, in the countries with highest mental health care provision, you have like, for instance, around 16% is the high. Okay, for depression and for anxiety, we go this like 18%. So with this study, we identify that we still have a lot of women that by one hand cannot be screened for their mental health issues, or they can have also some barriers trying to seek help for their mental health issues. Because in this paper, we just ask the women if they are receiving any kind of treatment currently for a mental health issue, okay? So we don't know if they were screened at the hospitals, for instance, or we don't know if they seek help, okay? So this is a limitation. However, this shows that there are still huge gaps on the capacities of the systems to screen these women. So these results show us that studies on both maternal and paternal perinatal mental health can contribute the way that we provide perinatal mental health care to both mothers or fathers. And today I will show you some research questions that we in our team are addressing regarding perinatal mental health in the last 10 years. Okay, so we have been addressing research questions related with both maternal and paternal perinatal mental health. We have been addressing questions related with the role of family processes during this period also. We have addressing questions regarding early infant development and mental health, namely regarding the impact of perinatal mental health problems on infant mental health. And we also have been addressing some research questions related with adverse contexts, adverse events. And here we have some studies on the COVID pandemic that we use to understand how life crisis can have an impact on perinatal mental health. So one of our main research questions that we are addressing is that what are the contextual factors associated with both maternal or paternal perinatal mental health, okay? And then we have been conducted several studies on this. One of the major factors that we are talking about this also in the morning, we talk about exclusive breastfeeding. And one of the factors that we are studying related with perinatal mental health is the role of exclusive breastfeeding. So this is a very nice study that we did like 4 years ago, where so regarding breastfeeding, we had some evidence showing that, okay, breastfeeding is highly related with depression and anxiety during pregnancy and the postpartum. By one hand, we know that women that have prenatal depression symptoms are more probable to cessate exclusive breastfeeding or even not initiating, okay? But also, we also know that when women initiate exclusive breastfeeding, this is very good for their mental health, okay? So, but the studies were like one study showing one hand and another study showing the other hand. And in this study, we try to look, okay, breastfeeding as a protective factor, but this protective factor happens for all the women or not, okay? Because we know that breastfeeding has a lot of benefits regarding biological, because it can happen, for example, to balance oxytocin, for instance. We know that the psychological point of view, it also helps to the women improving that parenting self-efficacy, but we don't know if the process are the same for women with or without mental health issues. So, and what we found in this study was highly interesting because we divided the women into groups. So the one that have prenatal depression and the women that don't have prenatal depression, clinical symptoms, okay? And then we assessed these women again at the postpartum period, and we asked them about if they were exclusive breastfeeding at the time or not exclusive breastfeeding at the time. And then if you can see, here you have the group that has prenatal depression, okay, and is currently exclusive breastfeeding later, okay? And here you have the percentage rates of postpartum depression, okay? And as you can see, in the women that is not depressed but is exclusive breastfeeding, the majority does not have depression at the postpartum period, and only 2.6% report prenatal clinical symptoms. And if you go also for the group that don't have depression and is not exclusive breastfeeding, is really the same. Okay, here you have 3%. Here you have 6%. It's really the same. But when you go for the groups that have prenatal depression symptoms, if you compare the group that was exclusive breastfeeding and the group who was not exclusive breastfeeding, you see that the rates of postpartum depression were really low in the group that has currently exclusive breastfeeding compared with those that has not. So here we maintain a half of the women still have clinical symptoms, but in the group that has exclusive breastfeeding, we have a decrease for 20%, which is a 30% increase, is very, very, very high. And with this result, we discussed that, okay, breastfeeding, exclusive breastfeeding seems to have a protective effect, but this protective effect seems to be higher for women that has symptoms during pregnancy. So maybe when we think about the practical issues on these results, we need to think that, okay, exclusive breastfeeding should be important for all of the mothers. Maybe not. Maybe it's important for those that could be a risk in terms of their parental self-efficacy, in terms of biological hormones, they need to be unbalanced at the time. So all of these issues can explain this protective effect of exclusive breastfeeding. But maybe for those who don't have mental health issues, maybe the process is totally different and the protective factor is not the same. Okay, so when you are thinking about the intervention, who should be screened, maybe we should consider these issues even in pregnancy. Okay. So, and then another contextual factor that we have been studying for some years was related with tobacco consumption during pregnancy. So this was a nice work that we did with some colleagues from Spanish. This is not from a Portuguese cohort. It's from Spain. Then we had this author, Beatriz Pereira, was doing her PhD with some internship, like Flavia did some time ago, with us at the University of Minho. And then we did some work on the association between tobacco consumption during pregnancy and the role of depression and anxiety symptoms. Okay, and then as part of this work, we were able to publish these two papers. In this paper, we try to understand how the tobacco consumption during pregnancy can lead to some symptoms of depression and anxiety also during pregnancy. How could this can interfere on women's mental health during pregnancy? And then in this paper, we also try to look if the women if the women with mental health issues during the perinatal period could be more probably to relapse on tobacco consumption in the postpartum period. So we know that many women stop tobacco consumption because of the pregnancy, but we know that many of them also start again smoking because they don't have the fetus they expect that this not have an impact on fetal development. However, we know that the effects of tobacco consumption can happen through breastfeeding, can happen through the environment in the home. So we conducted these two papers. In the first one, we tried to look what happens in terms of mental health symptoms in women that did not smoke ever, women that quit smoking at the 3rd trimester of pregnancy, and we compare with women that keep smoking all the time during pregnancy. And then if you look, you have a graph on depression and on anxiety symptoms, and then we just compare what happened in these groups in terms of their mental health symptoms. And then we found that continuous smokers during pregnancy were the women with higher depression and anxiety symptoms, both at the first trimester of pregnancy and both at the 3rd trimester of pregnancy, But more important, we found that in the continuous smokers during pregnancy, they did not reported the decrease on depressive and anxiety symptoms that we usually found in women during pregnancy. Okay, so if you look to these graphs, you know that if you look for the non-smokers, okay, for the quitters and the non-smokers, you see that both groups are decreasing, okay? But the group of women who keep smoking remains really stable, and we found not any changes in these symptoms, okay? So this could be also an indication that this contextual factor, these women who decided to continue smoking during pregnancy maybe present already some difficulties adjusting to pregnancy, adjusting to the transition to parenthood, okay? Both in terms of depression and anxiety symptoms. And then in the second study, so we looked for the relapse, okay? And actually what we found in this study, so we considered many covariates in this study. We asked the women about tobacco consumption, depression, and anxiety, both in the moments during pregnancy and the postpartum period. So we had like the trajectories. We talked about this in the morning. We had like these growth curve models for all of the women. And then we also controlled for previous tobacco consumption, because we know that many women could smoke, but the quantity of smoke is also important, okay? And then what we found was that women with more depression symptoms during all the time, women that remain with higher symptoms of depression across time, showed a higher probability, a higher tendency, were more probable to relapse smoking during the 2 months postpartum, so during the early postpartum period. Of course, this comparing with women with low depressive symptoms across the pregnancy and the postpartum period. So, trying to simplify this result, women with depressive symptoms can start early to smoking again during the postpartum period, okay? Even when we control, for example, with breastfeeding also, okay? So, also for the practice, it's also important because not only screening depressive symptoms, but including all of these kind of behaviors that women can present, tobacco consumption, alcohol consumption, other kind of consumption that women can have, can also be good indicators of their adjustment of their mental health issues during the early postpartum period. And then now we go for the paternal, perinatal mental health. No, we are changing to the mothers, to the fathers, okay? And then I think with 8 years ago already, we decided to do this study about what is the role of infertility treatment. Okay, so we have some studies showing that infertility treatment can, because it's a burden, because many couples are kept still looking for getting pregnant. Many of them are not succeed at the first time, so there is always this process is very difficult for the couples. And then we have a lot of studies analyzing what is the impact of doing these infertility treatments. And actually, the studies are not very clear regarding. So there are studies that usually found some differences. There are studies that also did not found some differences on mental health and other indicators. So even after because this is a study with fathers, that there are not so many compared with the mothers, we decided to conduct these studies to see the impact of infertility treatment in mental health of the father. So, and what we found, so here you have the group of fathers that we had that had some infertility treatment, okay? We have the group that the conception was natural. They don't give any treatment on this. And then here we assessed like we have a group that have clinical symptoms of depression, clinical symptoms of trait anxiety, so they are more stable anxiety than not a trait. And then here the state anxiety symptoms. And then here we also have the assessment in terms of continuous variables of the number of symptoms that the fathers reported. And if you look at the last column, the group comparisons, okay, we see that the prevalence of clinical symptoms of depression is higher in the group that did some infertility treatment. Okay, so if you like to look to this, so we found like 22% of men reporting clinical symptoms of depression in the fertility group, and then in the group that had a natural conception, we only have 7%. Okay, so we found here that the expectant fathers presented a higher prevalence of depression and anxiety symptoms. And then we also assessed in this study things not only depression and anxiety symptoms, and we also assessed if these fathers that did some infertility treatment could present some difficulties regarding the marital relationship, okay, regarding the attitudes towards the sexual relationship with their partner, and then attitudes toward the pregnancy and the baby itself. Okay, so we used here a questionnaire that is specifically developed to assess paternal adjustment and attitudes during the transition to parenthood. And actually, we also found that besides having more mental health issues, depression symptoms, fathers that had infertility treatment reported also lower marital satisfaction compared with the other group, more negative attitudes toward the sexual relationship, and more negative attitudes toward the pregnancy itself. So we have here an overall indication that these fathers could be at risk of more paternal adjustment problems, more problems adjusting to the transition to parenthood itself. Okay. Okay, and now we change the subject and we go for the role of couple relationships. So we have been studying couple relationships for some years. So we know for now that for many systematic reviews that when we look for the main predictors of depression and anxiety symptoms during pregnancy or the postpartum period, couple relationship is always popping up. Yeah, in a way or another, couple relationship is really important. And of course, we are trying to look better for the role of couple relationship. And in this paper, we try to look for one specific question, or maybe two specific questions. So the first one was that couple relationship is more the couple relationship that is a main determinant for perinatal mental health, or is perinatal mental health that determines the couple relationship. Okay, it's like what happens first. Yeah, it is a good way. It's a bidirectional probably effect. And then what we did in this paper was like we had this design of trajectories of depression, anxiety for pregnancy to 30 months postpartum. So we had this large period of assessments. And then we had the same for both couple relationship, positive and negative dimensions of the couple relationship. And then we tried to look for these trajectories, and we just tested two models. One model of depression predicting couple relationship, and the other way around, couple relationship predicting depression and anxiety. And of course, in this, we always consider if it's the same for the mothers and for the fathers. Okay, also interested in what is the importance of the couple relationship for each member of the couple. And what we found, so main finding was that it seems that is more the couple relationship that predicts the mental health than the other way around. Okay, so it seems that couple relationship can be like a protective or a risk factor for the perinatal mental health. Okay, and then here you have this graph that seems a little bit complicated, but I will try to simplify a little bit. So if you have here the depression scores, okay, reporting by the mothers and the fathers is an analysis of the whole sample, okay, and here you have the assessment waves that we conducted. So third trimester, second, third, childbirth, 3 months postpartum, and then 30 months postpartum. We have a huge gap between these two assessments, okay, and then here we have the trajectories of the couples that reported high negative interactions across this period, okay, this more dark line. And then in this gray line, you have the couples that reported less negative interactions, low levels of negative interactions across this period. And if you look in the group that have high negative interaction, we don't find any differences until 3 months postpartum, okay, during pregnancy. However, from 3 months to 30 months, they have a steeper increase on depressive symptoms. Okay, so it seems that couple relationship, it seems like a risk factor, negative dimensions of the couple relationship. It seems like a risk factor for depressive symptoms, but this seems to happen more in the postpartum period than in pregnancy. And it makes sense actually, because it's in the postpartum period that starts the real infant care, when the parents have to manage all of the caregiving stuff, the infant doesn't sleep, they have a lot of issues to solve, the parent goes to work already, and the mother starts dealing with sleep things, so it's a lot of stuff going on, okay? And the other important thing was that the effect seems to be higher for the fathers than for the mothers, okay? So it seems like that the couple relationship is more important for the father mental health than for the mother's mental health. And it also makes sense, okay? Because usually in more traditional countries, of course, this is Portugal, it's not so different from Chile, okay? It's really, the caregiving is still really similar, okay? And we know that usually the mother is the main boss in the room, okay? And usually it's the father depends more on the mother things, mother usually takes the decisions regarding the care, and the father is more dependent on what is happening with the mother. And we also have the things related with the gatekeeping, you know, the concept maybe, okay? That the mother usually is the main manager of the family regarding the infant care, and of course this puts the father in a more dependent way than the mother, okay? And then if you look to this even more complex graph, okay, this is really similar to the other one, but with 4 lines. Here we have anxiety scores, here we have the assessment waves, and then here you have the father's and the mother's lines, okay? So if we look to the fathers, okay, is the one with the triangles, I guess, I don't know in English, triangles, correct? Yeah. And then the mothers is like these circles, okay? So if you go to the fathers, you see that when the fathers have low negative interactions, their mental health is really great, okay? They are very stable, they don't have any change in the mental health. However, in the group that have high negative interactions, they have like a steeper decrease in depressive symptoms from 3 to 30 months postpartum, okay? So we found that this effect is only in the fathers, no effects for the mothers, okay? When we look for this moderation role, okay? Of course, this is one evidence. There are a lot of more evidences, okay? But the main thing of this result, I guess, is that we should, and it's still not happening, we should include fathers in the perinatal mental care, in the screenings, in interventions, okay? Even because we seem to know that they are at more risk than mothers at some periods of time, okay? So it's really important. So, and another study that we are doing more recently, this is from our recent study that I presented to you today. Okay, so we looked also what is the role of relationship satisfaction here in mothers again, but related with childbirth-related post-traumatic stress. So these results are from the Intersect study that Sol is also part of this team. Okay, and then we try to look in this paper if so we know that many women have traumatic childbirths. Okay, this happens a lot for many reasons, but we know that not all of them develop PTSD symptoms. Okay, so most women are able to process the trauma, others are not. Okay, and here we try to understand, okay, maybe couple relationship could be also a protective factor that can protect women to develop CVPTSD symptoms regarding the childbirth. Okay, and then actually what we found, if you go through these 3 graphs, okay, here you have the women that have low satisfaction with the couple relationship during pregnancy. Okay, there you have the women that reported medium satisfaction, and then we have the women that reported high satisfaction. Okay, so if you look for the women that reported high satisfaction, we don't find any differences. Okay, we don't find even an association between traumatic childbirth and post-traumatic stress. There is not a significant association, okay? But then, when we look for the group with medium couple satisfaction and this with low couple satisfaction, we found that the association between traumatic stress and between traumatic childbirth and traumatic stress was significant and much higher. Okay, so here we discuss this possible protective effect of couple satisfaction in this association. So maybe this previous couple satisfaction, because we assessed couple satisfaction in the prenatal period, not after child, okay? Maybe this good relationship with a partner can help women to process this traumatic event when it happens. And then we go deep, we looked further on this, okay? And then in this paper, we also looked what happens if partner support during pregnancy, when the partner of the mother is present in the childbirth, if this can protect the mother from developing some mental health issues during the postpartum period, okay? And actually, what we found here was that women that reported higher partner support during childbirth. So here we asked about the quality of the support. So we asked the women, okay, how good was the support that your partner provided to you during childbirth? Okay, and we analyzed this in association with depression, anxiety, and CBPTSD symptoms. And actually, we found that partner support during childbirth was associated with both depressive, anxiety, and childbirth-related PTSD symptoms. So maybe also what this shows how is the role of the couple satisfaction of the couple relationship in terms of the moment of the childbirth. This can also protect the women to maybe having this traumatic experience and developing later CBPTSD symptoms. Okay, and then we just now we were looking for the role, the factors that were associated with mental health issues, both in the mother, both in the father, different kinds of contextual factors, things related with couple relationship, things related with behaviors and environments of the mothers and the fathers. And now the other main question that we are trying to, that we have been addressing with our studies is that, okay, what is the impact of mental health issues in parenting? Okay, we know that one of the issues that show us perinatal mental health as a main public health issue is, of course, the impact that it has on the parenting and the child development. Okay. So regarding this, we conducted this study almost 10 years ago. It was a really nice study that we conducted with fathers, that when we try to look what are the trajectories of parenting self-efficacy in the father. So we know that parenting self-efficacy is a main dimension of parenting, yeah, because we know that when the parents feel confident, feel competent of implementing their parenting skills, of course, they are more able to do this in a good way. And even when they are bad doing it, they feel that they are good and, okay, this is the best approach. And in this study, we try to look, okay, what happens with parenting self-efficacy since pregnancy until the postpartum period, okay? And then we looked also how depression and anxiety could interfere and could impact these trajectories. And actually, what we found here, so here you have parenting self-efficacy. Then here in this study, we assessed the fathers at the first trimester of pregnancy, third trimester of pregnancy, 1 month postpartum, and 6 months postpartum, okay? And all of the assessment waves, we asked the fathers about their parenting self-efficacy. We use the Caritan Parenting Confidence Scale, okay? And then we also ask them about depressive and anxiety symptoms, okay? And then regarding depression, we did not find any effect, okay? When we looked to anxiety, okay, if you can see here, we have here the trajectory of fathers that reported high anxiety symptoms across time. And here you have the group of fathers that reported low anxiety symptoms across time. And here we found two main results. So we found that parents that have higher depressive symptoms already in the first trimester of pregnancy, fathers already have less parenting self-efficacy, okay? And then if you see across time, they have a little increase of parenting self-efficacy. Okay, and then in the end, they remain with lower levels of parenting self-efficacy compared with the fathers with low anxiety symptoms. Okay, so this shows that the impact of perinatal mental health issues can happen as early as the first trimester of pregnancy. Okay, and then it can remain and can interfere in the way that parents adjust to transition to parenthood. Okay, they always perceive themselves as being less able to perform the parenting tasks. Okay. And then we did also not the same, but we found similar results for the mothers. Okay, was a study that we just published very recently. We developed this study to validate the Caritan Parenting Confidence Scale to mothers in Portugal. Okay, and then of course in this analysis we also analyzed how depression and anxiety symptoms could be related with the scores of Caritan Parenting Confidence Scale. This study was conducted only the postpartum period, so here we don't have evidence on the pregnancy itself, okay? But regarding the postpartum period, we had women that reported parenting self-efficacy at 3 months, 6 months, and 12 months in different periods of the postpartum period. And then we correlated the levels of parenting self-efficacy, okay, with the Caritan Parenting Confidence Scale, with both depression, state anxiety, and trait anxiety in the women, okay? And if you can see, we have medium-sized correlations identified that higher levels of depression and anxiety, both at the state and the trait level, is associated with lower levels of parenting self-efficacy, also in the mothers, okay? So with this evidence, we can also discuss and that the role, the risk factor, the impact, the negative impact that perinatal mental health issues can have on this cognitive dimension of parenting in mothers also. Okay, and then we also did this study only with fathers, okay, when we looked for the impact of depression, but then on their paternal adjustment and paternal attitudes. You remember the dimensions that I showed you early, marital satisfaction, attitudes toward the pregnancy, and attitudes toward the sexual relationship. And then in this study, we also looked for the trajectories, and we tried to see what happens, what is the impact of depression symptoms on the paternal adjustment in the father across time. Okay. And then we have this study with 2 assessments. We have the second trimester of pregnancy and we have the 6 months postpartum, okay? And here you have the scores of paternal adjustment, okay? Reported by the fathers. And then, as you can see, in fathers with low depressive symptoms, the dark line, we found an increase on the adjustment across time, which makes sense. The fathers are performing the developmental tasks of this period, and they are adjusting to this new role. Okay. On the other hand, in the group that reported always high levels of depressive symptoms, we found a decrease on the adjustment across time. Okay, so the father started with 997 and they end up with 88. Okay, and is actually interesting, and then I can also share these results to you because this questionnaire that we have has a cutoff point, so we are able to screen the fathers that maybe have some adjustment problems to this father role, and then the value of this group is really close to the cutoff point. So maybe this group could be really, in terms of risk, at a higher risk of presenting clinical significant problems. And then we also conducted another study. This is about the fathers also, okay? And then we also developed this study to validate a measure, to validate a measure for Portugal to assess paternal involvement in the infant care, okay? So how much the father is able to change diapers, how much the father is able to how much it involves itself. It's not how capable it is, but it's about what kind of things he does, okay? And then we have also a version from pregnancy and a version for the postpartum. If you have also interest in this questionnaire, I can share with you, of course, okay? And in this study, we also tried to assess what is the associations between the levels of involvement in infant care and the association with depression and anxiety symptoms. So if you look to the first two lines, we have here anxiety symptoms. Here we only have state anxiety, we don't have the trait. And we have also depressive symptoms assessed with the EPDS. Okay, and then we have the same in the postpartum period. And as you can see, both in pregnancy and the postpartum period, we found that higher levels of depressive and anxiety symptoms are associated with less involvement in the infant care. Okay, so of course, we talked about this in the morning. This is a cross-sectional study. Okay, we did cross-sectional analysis, so we cannot make any assumption of causal relationships, but we can discuss some possible impact of also depressive and anxiety symptoms on the father's involvement in the infant care. Okay, and then this is interesting because the scale has two subscales. These household tasks, how much the father is involved in the household tasks and how much the father is involved in the infant care tasks. And we found associations also with both dimensions. Okay, and then our next question that we are addressing also is about the impact of perinatal mental health on co-parenting. Okay, we know that parenting is a main dimension related with infant development, but we also know we have also recent studies showing that co-parenting seems even more important for the infant development than parenting. We already have recent studies showing that when we look for the effects of parenting and co-parenting on infant mental health, we found that the impact seems to be higher of co-parenting than of parenting. Okay, and then we have some studies that we conducted to look for the impact of perinatal mental health problems. This was also a study that we conducted in Father about the co-parenting relationship scale that assesses the co-parenting expectations, okay, of parents during pregnancy. Okay, and then as part of this analysis, we also looked what is the association of depression and anxiety symptoms also with the co-parenting expectations of the father. And as you can see in these cross-table correlations, you see that more prenatal depressive symptoms were associated with more expectations of conflict, okay, from the father to the mother. Okay, so this is the report of the father, while more prenatal anxiety symptoms were expectations with more expectations of disagreement. Okay, so we found here that in different ways, in different dimensions of co-parenting, depressive and anxiety symptoms seems to be associated with these dimensions. Okay, of course, at this time because we assessed fathers at the first trimester of pregnancy here, so we know that as part of the transition, parents are still developing that co-parenting identity, how we want to be as a co-parents, and of course, these expectations can also be related with the quality of the couple relationship. And then we also are looked for the impact of perinatal mental health problems on the infant development. So some years ago, we conducted this study about the impact of maternal depression and anxiety on fetal neonatal growth. So we assessed the mother and the fetus at the time across pregnancy and until childbirth. And we try to look for the effects of both depression and anxiety on the fetal growth. So basically, here we had the reports of the hospital regarding the fetal weight across each echography. So we had the second trimester, third trimester, and then we have the childbirth assessment. Okay, and then in between each time, we ask the mother about their depression and anxiety symptoms. And actually, what we found is that depression did not have any effect on the fetal weight growth. However, we found an effect of anxiety. Okay, and then what we found was that in the group of mothers with higher anxiety symptoms, okay, as you can see, fetus have less growth across pregnancy until childbirth. Okay, and even if we look to the mean scores of weight, you can see that the babies that born from mothers with high anxiety, born with less than 2,050 grams, that is the cutoff for low birth weight, while the infants, the neonates from mothers with low anxiety symptoms born with a weight above 2,050 grams. So here we found some impact of anxiety symptoms on the fetal development in terms of physical growth. And then, more recently, we also try to look for the effects of prenatal depression and anxiety. In this paper, we actually only looked for the effect of depression, but now not for the physical development, but for the neurodevelopment of the baby, okay? And then in this study, we had this design with mothers with depression, with and without clinical symptoms of depression. And then we also assessed fetal heart rate during the cardiotocography in pregnancy, okay? And then we also assessed infants after childbirth, like 3 to 5 days after childbirth, okay? And then we assess fetal heart rate variability because we know now that this is an indicator of fetal neurodevelopment, okay? Higher heart rate variability is an indicator of good neurodevelopment, okay? So we try to look, by one hand, is if depression symptoms can have an impact already on fetal heart rate, and later, of course, in neurobehavioral maturity of the baby as a neonate, okay? And then in this table, you can see the mean score. So we assessed the fetal heart rate variability across different conditions. We had a pretest, we had a familiar stimulus that was presented to the mother, a novel stimuli, and a post-test. Okay, and then across all of these times, we looked for the levels. We compared the levels of heart rate in both the group of fetus from depressed mothers and mothers without depression. And actually, we found that fetus of depressive mothers showed already lower fetal heart rate variability, which maybe is an indicator of lower fetal neurodevelopment, okay, already in pregnancy. And then when we looked later from there to their neurobehavioral development, okay, we did exactly the same. We used the NBIS, you know, the neonatal behavior assessment scale, okay. Then we when we assessed also all of the babies from mothers with depression in pregnancy and the group that has no depression in pregnancy, and we also found that these same babies that have lower fetal heart rate variability in the fetal period already presented lower autonomic stability, okay, lower stability in their autonomic nervous system, okay, showing here that depressive symptoms, clinically depressive symptoms, can have an impact already during pregnancy, and this impact maybe has a long-last effect to the postpartum period. Okay, and more recently, we decided to replicate the same study, okay, but now we try to look for the effect later at 3 months postpartum, okay? We consider at the same fetal heart rate variability as an indicator of lower, this is a different sample, okay? It's not the same sample of the other study. And then here we also looked what happens in terms of fetal heart rate variability, and then what happens in terms of regulatory capacity in the baby, okay, at 3 months postpartum. And then we found really similar results, okay? So we found that mothers' depressive symptoms were associated with lower fetal heart rate variability, okay? So this impact seems to happen again with a different sample, where we found also lower neurobehavioral development in the fetus, okay? And then later, when we looked for the infant self-regulation, we also found that higher prenatal depressive symptoms were associated with lower regulatory capacity in the baby, okay? This is important to tell that we control these models for postpartum depressive symptoms, okay? Just to assure that the effects are not due to the mental health issues of the mother during pregnancy, during the postpartum period, but during pregnancy, okay? And actually here we found similar results as the ones that we found in the other study, but later in the baby life, okay? And then we are also looking for what happens in terms of infant sleep problems, okay? In this study, we try to understand if these effects could be only on infant self-regulation, but in another dimensions that is related with sleep. We know that sleep is a main issue during the postpartum period with the babies, yeah? And we know that infant sleep is highly related, by one hand, with the caregiving practices, we know, but we know that it's highly related with temperamental issues, okay? We know that there are infants that they born and they arrive to the crib and they stay, okay? And on the other hand, we have babies that they don't stay anytime in the crib, okay? So we know that is highly related with these temperamental features that are also highly related with some regulation capacity that the infant has, okay? Some temperamental regulation, okay? And then we try to look that if prenatal depressive symptoms can be associated with sleep problems in the baby later, and this is happening through temperament, okay? And then actually what we found here, okay, was that prenatal depressive symptoms were associated with higher sleep anxiety in the baby, okay, higher difficulties to maintain sleeping. And then part of this effect occurs through the effect of negative affectivity in the baby. So this happens because the baby has higher levels of negative affectivity, and this is also associated with higher probability of sleep problems, okay? So in this study, we try to show that, of course, prenatal depressive symptoms has this effect on the baby's sleep, and this seems to occur also according what is happening in the fetal period, altering the fetal neural development and also infant temperament. And then more recent, so this paper is not published, but I think will be published in the end of the year. And in this paper, we also included the father, okay? And we are trying to look what is the impact of both maternal and paternal depressive and anxiety symptoms on infant mental health problems later at 2 months, at 2 years postpartum, okay? And then, so we try to look, so to explain to you the big picture first. So I ask you here to do not take any pictures because this data is not published, okay? But of course, if you want any of these results, just write me and I of course be happy to send to you, okay? So in this paper, we try to address one main question that was if is more anxiety or depressive symptoms that can explain why the infant has mental health issues. Okay, was the first end. Is depression or is anxiety? And the second question was more the mother, was more the father? Okay, and the third question was, is there an interactive effect between the mother and the father? So when the mother and the father have depression or anxiety, this is worse for the baby or not? Okay, so main issue. Depression seems to be more associated with mental health problems in the baby than anxiety. We did not found any effects for anxiety, only for depression, okay? And then when we looked for the main predictors, okay, we found that the mother's prenatal depression is a main predictor of internalizing and externalizing problems in the child at 30 months postpartum, okay? And besides the mother, we also found that the father's depression in the postpartum period at 3 months postpartum was also the main predictor of the children having problems later, okay? And we found this when we account for in the same model for both the mother and the father, okay? And then we found that the father APDS scores, the father depression symptoms, postpartum depression symptoms, was more important to explain the problems in the child than the mother, okay? And was according to this result that we try to look, okay, is there here an interaction effect? Maybe we have some moderation here, okay? And then what you have here is that, so we have here the internalizing and externalizing symptoms in the child. So with the CBCL scores, we also talked about this in the morning. Then here you have the scores, the depression scores of the mother during pregnancy, okay? And then in the lines, you have the levels of the father's depression during the postpartum period, okay? Here is the fathers with low depression scores, medium depression scores, and high depression scores, okay? And then if you look for these different lines, we see this dark line that when the father has lower levels of depression, okay, the child does not have any mental health issues, independently of the mother having low or high APDS scores, okay? However, when we look to the group with higher, when the father has postpartum depression symptoms, the problems in the child increase much higher when the mother also has mental health issues during pregnancy. Okay, so the main result for us here was that good mental health in the father, it could be like a protective factor for the child to develop symptoms even when the mother had prenatal depressive symptoms. Okay, it could be like a good protective factor for the child. So once again, when we are looking for the screenings, for the interventions, we need to consider the mental health of the father here in the equation. Okay, and then because we know this importance of father, importance of mother, mental health, so we try to look which are the factors, which is the role of the family processes in all of these equations. So we decided to complicate the thing, and then let's put more variables in these equations. And now we conducted these studies where we looked, okay, what happens with which is the role of the family processes in infant development. And then we conducted this study some years ago when we tried to look that, okay, we know that couple relationship is an important thing for the mental health of the mothers and the fathers. We know that it can be a protective or a risk factor. And our idea was that maybe the effect of couple relationship on infant mental health could happen through the decrease of mental health problems. So maybe when parents have good relationship, this can improve their mental health, which leads to higher development of the baby. Otherwise, when they have a bad relationship, this could increase perinatal mental health problems, which could later lead to problems in the baby. And then was the thing that we tested in this paper, okay? Then we tested like different kinds of mediation. So we assessed each time couple relationship in pregnancy and postpartum, and also depression and anxiety, and we tried to test for some mediation effects, okay? And actually, we found that both maternal and paternal depression mediated the association between couple relationship quality and infant mental health problems. So when the couple relationship is bad, this is associated with higher depressive symptoms, which later is associated with mental health issues. So here we try to find that which is the role of couple relationship in the association between mental health in the parents and in the baby. And then more recent, we try to look also which is the role of co-parenting. Okay, so I show you already that there is a lot of evidence about the prenatal depression and infant regulatory capacity, infant social emotional development, and we try to look, okay, but maybe co-parenting could protect babies during the postpartum period, yes or not? Okay. And then in this paper, we also try to look which is the role of positive dimensions of co-parenting and negative dimensions of co-parenting, namely conflict. Okay. When we looked for positive dimensions of co-parenting, we did not find any effect. Okay. But when we looked for the co-parenting conflict, okay, the issues of conflict between the couple related with co-parenting practices, not about the couple relationship, okay, we found actually that in the couples that have high conflict, okay, this increases the probability of the infant having regulatory problems later, okay? So here you have the regulatory levels, of capacity levels of the baby, okay? Here you have maternal prenatal depressive symptoms, the mothers that reported low levels of symptoms, the mothers that reported high, and then later we have co-parenting assessed at 2 weeks postpartum. We assess co-parenting really after childbirth, okay? And then we found that in the group with high co-parenting conflict, okay, we see that when co-parenting conflict is high and the depression is high, this increases the probability of regulatory problems in the baby, okay? They have lower levels of regulatory capacity at 3 months postpartum, okay? So co-parenting conflict can be a risk factor that can increase the adverse effects of perinatal depression on. Okay, then we already have a high trajectory of these different impacts, these factors associated with perinatal mental health. And then I just want to show you some studies we conducted in cases of adversity. Okay, so we conducted some studies on the COVID pandemic, as many researchers did this, okay? And the main issue, the important thing of these studies on the COVID pandemic was that it's like a laboratory crisis for us to understand what happens with couples in these adverse situations, okay? And then we looked for anxiety and depressive symptoms, okay, also, and couple relationship. And we compare, we had this cohort, actually, this was the study for my PhD, okay? And then actually at the time, I don't have any pandemic, okay? And then in March, we had the pandemic, okay? And the good thing for me, okay, because the pandemic has good things also, was that some part of the sample had not assessments yet. So they were already assessed both before the pandemic and during the pandemic, okay? So I was able to compare the sample that never went for the pandemic with a sample that have the pre and the post-pandemic, okay? And this was nice because I was able to look for some possible effects of the pandemic on this, okay? And then when we looked for the two samples, the one that was assessed before the pandemic and the sample that was assessed during the pandemic, we compared both mothers and fathers in terms of depression and anxiety symptoms, okay? We included both members of the couple, and as you can find here, we only found effects of depressive symptoms, okay? So the group of mothers and fathers that were assessed during the pandemic reported also more depressive symptoms, but not higher anxiety symptoms, okay? And this was assessed at 6 months postpartum, okay? And we controlled also in this model for the levels of the parents before the pandemic, okay? Just to adjust if this could be related with the mental health issues, the previous mental health issues. And we did not found any effects of gender. The effect seems to be equal for the mothers and for the fathers. And then we also did the same for the couple relationship. We compared the two groups on the positive dimensions of the couple relationship and the negative ones. And actually, we found an effect on the negative dimensions of the couple relationship. So the group that was assessed during the pandemic reported more negative couple interactions at 6 months postpartum than the group that did not. So this was what we were expecting regarding the impact of the pandemic. And then we also looked for the possible impact on the baby already, okay? So we also compared what happens in the parents, but also what happened regarding the socio-emotional development of the baby, okay? And here we also included the assessment of infant regulatory capacity, okay? And actually we found that the group of babies assessed during the COVID pandemic also reported lower levels of regulation compared with the group that was assessed before. And of course, this could be also related with what happened with co-parenting, what happened with the couple relationship, and what's happening with the mental health of these parents. Okay, so I show you a lot of questions that we have been addressing in the last years, okay? Now we have new ones, and it's just to show you what kind of things we are doing now, what are our next questions, okay? So now we are trying to address one main question, that is what happens in parent-infant interactions early in life, okay? So we are trying to look what happens during moments of mismatch and reunion during interaction both with the mothers and the fathers, okay? Using, of course, not only a behavioral, but also a neurophysiological perspective, what happens in these different perspectives of the functioning, okay? We are also trying to look what is the impact of perinatal mental health problems on this biobehavioral synchrony, also during parent-infant interactions. trying also to look to the possible differences between the mothers and the fathers. Okay, we know that we have a lot of work from Ruth Feldman, maybe you all know on this, and on the role of father, but we don't know for now what really happens with the fathers, if it's different, is the same what happens with the mothers. Okay, and of course, considering all of these factors, how these factors interact to explain the etiology later of mental health problems in the baby. Okay, and basically how I just want to show you how we'll address them in the next years. Okay, so we have this early life cohort that we are doing now. For those that already went with me in the morning, you already know much more about this. Okay, but just to show to you that now, just to address these specific questions, we are having this longitudinal cohort in Portugal, where we are following families from pregnancy to the postpartum period until 2 months postpartum now. And then these families are being contacted at public hospitals during pregnancy. Okay, and then parents and infants are being followed across the first years of life. We have this multi-method approach with observation, laboratory assessments, questionnaires. We have also clinical interviews, and then we are specifically looking for what happens in the brain of parents and infants while they are interacting at the lab. Okay. This is our team for now. We have people from psychology, from neuroscience helping us. We have great PhD students working with us. And that's it. Thank you so much. Yeah.
Thank you, Tiago, for your presentation, for sharing with us your great work with you, your team, and to show us there's so many layers where perinatal mental health can influence family and individual outcomes. So if there are any questions.
I don't know if that is in the chat. No, it's okay.
In the
Okay.
chat, questions.
If I'm thinking about like the baby as an agent, so how would you study the impact of the child's regulation on the parent's regulation?
I think we have many ways. Okay, I think one main approach is that if we have an indicator of temperament, okay, at least as early as possible, or in the fetal period, or even after the child is born. Okay, I think it's important. And even, for example, with NBIS that I showed you early, we can have some indication of the ability of social processing of the baby. We talked about this in the morning. And then with this indicator, you can see that if the baby has more social competences in the way that the infant interacts with the parents, we can have different groups, different kind of groups of babies. It can be a good way, for instance. Okay, or you can have a baseline also. If you have a assessment baseline before the interaction, you can look if this is different according to these characteristics. Yeah, could be a good way. Because it was a thing that we were talking in the morning. There are babies that they are interacting with the parents. The parents are really sensitive, responsive. They try to adequate the interaction to the baby needs. And there are babies that are always crying. The parents, they don't know any more what to do. And otherwise you have babies that the parents are not responsive. They are just there and the babies are just okay. So it's really easy. I think there is a part of this process that is related with biology. I really believe this. But of course, we also know that this kind of neuro development programming that happens in pregnancy is already related with the mental health of the mothers and the fathers. So this is like, yeah,
Thank you for your presentation, Tiago. I wonder if you have any thoughts about the role of stress. And the reason I'm asking this is that in the studies we've conducted here, we've seen that anxiety and depression tend to be quite stable at first time, and they are hard to change. But sometimes stress is more dynamic and can, I don't know, can be modified more easily. And I wonder if you have any thoughts about this.
It's a really nice question, because actually we are not exploring the role of stress. Of course, in anxiety, we are trying to assess anxiety at a specific moment. So I think it's a little bit related with the stress, but stress has been studied in a lot of studies, and we found also it really affects in the fetal neurodevelopment. Yeah, so the stress is also a main dimension to study. But actually, I remember now there are interesting studies, I think from Catherine Monk. Do you know Catherine Monk from US? Their team, they have a really nice research work with stress, and actually they found that for the neurodevelopment of the fetus, medium levels of stress are the good thing. So when the mother has very low levels, this also this can be a little bit bad, because it can be related with some difficulties also regulating the stress system, because it's supposed that we have certain levels of activation, and from some others this cannot happen, and it's also bad from the baby. So stress is also a good thing to study. Yeah, it's a major role here.
I always have another questions for the
In Spanish.
yeah.
Go ahead.
Me encantan esos estudios, pero están hechos en recién nacidos de término, ¿cierto? ¿O hay prematuros también?
So in our samples are from community, okay? So most of the babies born post-term, okay? But we always have like 10% of preterm babies. But usually we adjust the models. What's what we talk about in the morning? Usually we adjust the models for prematurity, or we exclude them from the studies.
Claro, porque ahí las mamás tienen mayor riesgo de tener estrés, depresión, ansiedad. ¿Cómo impacta en el neonato, en la salud mental del neonato y en el desarrollo?
Actually, yeah, it's really true. And even the process, because we know that prematurity is also associated with higher probability of being in the NICU, in the neonatal intensive care unit. And of course, this is an adverse condition from the mothers and fathers. Yeah, it's true. Of course, good question.
How are you applying all these results in the public policies in Portugal?
Yeah, this is
How are they, in preventions programs, or this is a lot of information, I mean, wonderful information, and how do you use it for the society? I mean,
so
how
it's
is the university?
yeah, this is a really good question, because actually I think that for us researchers, the most difficult part is to transform all of these results in things that the community can understand and can perceive the impact. Now, personally, what I'm trying to do as a researcher is that I'm trying to become more involved in presentations in hospitals, in events that are directed to the community, just trying to translate these results for the non-academic. Yeah, and the university, our research center, is highly committed now to do this with all of our studies, trying to disseminate the results in the social media, also in events in public places. So we try to do like this, yeah, but it's difficult to arrive there. It's difficult, yeah. Nice question.
Yeah, we have a question. First of all, thanks for the presentations. How do you propose to involve the parents in interventions?
Wow, this is a huge question.
Something that is like really change.
Yeah, so thank you so much for the question. This is one of the main issues that we have. I think that I never went to practice in the hospital, okay? I'm the kind of academic that I did my master, my graduation, master, PhD, always in the university, and I start teaching. It was like this. But one thing that we have this evidence from many interventions, that we have these prenatal classes in the hospitals, okay? And this, in Portugal, for instance, we have the father that now is in these prenatal classes. So it's a moment that we can use these classes not only to explain how will be the childbirth and we have to breathe 3 times, 4 times, but to discuss many of these things that can be worries for the parents at the time. So we can work co-parenting, we can work how the couple relationship is, difficulties that the parents have. We can discuss them in this place. So I think it's a good start, yeah, to work with these parents. Yeah. Spanish.
Lo siguen hasta el primer año de vida los bebés.
Mhm.
Y después ya no.
No, now we are going until the 2 years.
Ah, okay.
Okay, and the idea is to go until 5.
Okay.
But we need time. Yeah.
Yeah,
Yeah.
we need
Yeah.
to
But
go
the
up.
idea is to keep following the families across time. Yeah. And trying to look for possible generational effects later. Yeah. So let's see how the.
Yeah.
It's always the problem.
When you mention stress and that it's better to have like a medium level of stress, is it having a medium level of stress or is it like being flexible in having stress and regulating from stress?
You are a kind of student that asks very good questions. I don't know.
You?
Yeah, it's very problematic to say this to you. So when of course.
Just to record with you.
Never repeat it again. Never. No, but the truth is that when we talk about these, of course, is different when we assess stress in a stress-inducing condition. For example, if we have a lot of studies assessing stress in the mother during some cognitive tasks, for instance, okay, and then we have like activation of the system, and then it's different when we ask the parents about their levels of stress in a certain time. That could be they don't have the stress activated, and they could have, we don't know, yeah, but. We know when we talk about this medium stress level is like an indication of activation of the system. So is actually the way that you are saying. If you have like some variability, yeah, we have like some regulating system working. Okay? And if you have always low levels, maybe this can be problematic, of course. Yeah, but it's related with the regulating stress system. Yeah.
Maybe a more technical question. Do you measure synchrony?
Yeah, this is the most technical question. Yeah, it's a very, very good question. So now we are using, so for behavioral synchrony,
Okay.
we are using the global rating scales to assess parent-infant interaction. It's like an observational system that we assess sensitivity, responsiveness. And then we have these subscales that assess the diet. Okay. And we have one dimension that is involvement in interaction. Okay, and then they propose that behavioral synchrony can be assessed with the involvement, the mutual involvement of both the parent and the infant in the interaction. Okay, this is for the behavior.
Okay.
Then for the brain, that is a more complex thing. Okay, so we know that theoretically, this is the attunement between the parent and the baby in a certain time during interaction. Yeah. But in practical, we have different ways of looking to these. We have correlations, we have the coherence. Now we are analyzing with the coherence stuff. So the levels of blood that the blood flow in the brain, in the parents and the baby across each condition of the interaction, okay? The problem now is that even with the most experts on FNIRS, because we are using FNIRS to assess brain synchrony, they don't know yet how we can assess synchrony with babies. So now we are defining a pipeline just to do this. Yeah. It's a new job. Yeah, but it's very good because actually it's interesting because Now we have standards to assess synchrony in adults. So we have a lot of recommendations for babies. We don't have anything. So I think our results could be really nice because we can have also some methodological standards to other researchers who are conducting research in this area. Yeah.
But I understand that in adults, there are a lot of discussion about
Yeah.
how to measure.
Yeah, the problem, of course, related with the brain. The problem is the level of estimation that we can do with each blood flow. Then we have a lot of restrictions with so a lot of results, a lot of data goes to waste. And then in the babies, we don't know if we can do the same or if we can have a new value definition for this. So I think it's one of the problems. But I think the thing with these results is that we know that synchrony is not always good. It's not supposed that while we are interacting, we are always synchrony. So sometimes we are in a mismatch situation, other we are in a reunion, we are synchronous. And then I think understanding what happens in moments of still between the father or the mother and the baby and moments of reunion can help us to understand which is better in which times of interaction in terms of brain.
I was going to ask, yeah. I think it's the same that you just said, but like instead of focusing on synchrony, focusing on what happens after mismatches.
Yeah, so we are trying to look what happens, which levels of synchrony have in periods of mismatch and in periods of reunion. So if you think theoretically, it is supposed that in I say a healthy parent-infant relationship, you could have a decrease in synchrony during mismatch, and we can have a higher synchrony in periods of reunion. It's what makes sense. But actually, what we don't know is what happens when the parents have mental health issues, when the parents have other difficulties. Maybe in some cases it could be always synchrony and higher and always low. And actually, we have some data with older infants from Pascal Vitrka, that is from Essex in UK, and he's studying the levels of synchrony in I think he's in school age children already. Okay, and actually he found that higher synchrony always in parent-infant interaction is associated with more insecure attachment. And it makes sense because this higher synchrony always it can be related with the afraid that the children have of their abandonment of the parents. So they are always compliant in terms of synchrony. So it's really tricky to see this thing. So let's see.
Made me think of the respectful parenting approach.
Yeah, but it's a lot. I think it's a lot to solve in these pieces. Yeah.
Maybe recuerdo que en un estudio en Chile, muchas mamás con diagnósticos de problemas de salud mental perinatal no continuaban tratamiento por el temor al efecto de los fármacos, como tocaya, que tienen el mismo problema.
So in our studies, we have two things. We have we ask always in our studies if the women has doing treatment, even psychotherapy or any meds. And actually, what we do that we control for this variable, or we just retrieve the women from the sample. But usually we don't find any effects of this. So usually it's not a variable that interfere on this, of course, this association. Yeah. Yeah. But of course, it's also a barrier for treatment because, and many women are also think that the meds can interfere with breastfeeding also is another issue. And then, of course, we need to clarify this. We need to do in the hospitals, say the women that the meds should be adapted to their condition and not the other way around. Yeah, it's true. Is another issue. Yeah.
Well, thank you so much for assistance. Thank you, Tiago, for your presentations, and we are ending this space.
Thank you so much.
Thank you.
Thank you. Thank you all.